Good morning, everyone. Thank you for the opportunity to to speak about newborn screening. That was my second life that I always had besides creatine deficiency or GAMT. So now it was great to have the opportunity to work on combining that. So try to imagine that you are members of an advisory council that has to advise your legislature whether or not to add a new screening condition. So and I am the one who tries to convince you that you should decide for GAMT, okay? So that's the plan. I'll see how effective I am, that I showed you yesterday already. So the problem with very rare diseases is where comes the evidence from that early detection, early treatment is really beneficial. And that was a struggle with GAMT deficiency. The clinicians that have seen the difference, they were convinced. The families, the very few families that had the opportunity to see the difference between late treatment and early treatment, they are convinced too. So, but that is a very small group of people. Anyway, we decided one way, because doing a prospective study is almost impossible. That's not an option. It will take way too long. And getting those patients, if you don't screen, how do you find the pre-symptomatic cases? It's a kind of a vicious cycle. So we thought we try to find those families that have two children. The second child in those families with GAMT deficiency, the second child usually is identified early because the new kids born after family has already an affected child are usually tested early because there is a 25% likelihood or chance that another baby could be affected. So we were able, with help of ACD, to identify 4 families with children where one child has been diagnosed later, although one has to say one of those 4 families, even the later diagnosed child was diagnosed at 18 months, so that is relatively early. And in one other family, the treatment of the early diagnosed child was a little bit later. So it is not very homogeneous, but we have, for example, 2 of the kids have been diagnosed basically right after birth and started on treatment. Anyway, we had 4, and we wanted to make this a controlled study. If you compare siblings and you find differences, someone could say, oh, that is also what you see in healthy siblings. They are not the same in terms of development and so that is why we also enrolled 8 sibling pairs from families with no known disease. So we initially did structured interviews where Leora, my research coordinator, called the families with children with GAMT and asked them about their children, so just tell me what they do and so on. Based on those reports, we then designed a questionnaire that would tries to more quantitatively identify those differences. And then this questionnaire was sent to those 4 families. They had to answer those questions for each of their 2 children. And it was also sent to the 8 families with 2 healthy siblings. And so that was. And we focused, of course, on those areas where GAMT deficiency causes deficits and problems. So these are the results. We have not published it yet, except in a poster, but I really hope that we will be able to do this in the next 2 months. And so what you can see, do you see it? Yeah. So this area here, our domain is developmental milestones. So pretty easy. Sitting, standing, walking, first words to the first 2 to 3 word phrases. And you can always see blue is normal, red is delayed, and green very delayed, and never. So and you have in the first column is the control siblings, so those 16 control siblings, and then the next is the GAMT, the young child, or early diagnosed child and treated child, and the right is the later diagnosed and treated child. So for sitting, for example, you can see that almost all of the later treated children were delayed. Same for standing, same for walking. Even more obvious, and that is not a surprise, is speech. So you can see that in the later treated group, some never developed speech, and others were very delayed, and none of that happened in the control group. So there's already a clear difference. And you can also see some comments that the parents made about their children. You may not have the time to read all of this, but yeah. So next, cognitive skills and school program. And so there, for example, we choose able to understand and follow instructions, while in the control group that usually was not a problem, and in the kids that were earlier treated with GAMT, also not much. You could see in the older group a huge difference. Same applies for the school program. So blue means regular class, regular is regular, red is regular class with support, and green is special education classroom. And you could see the older kids, all of them, or the late treated children, all of them were in those special classes. Next is fine motor skills. So, for example, teeth brushing. The early treated, no problems. The healthy kids, no problems. And in the older, later treated group, you could see almost, there's only one that was able to brush the teeth. And use buttons and zippers, same here, only one child. And I mentioned that in the late treated group, there was one that was still already treated in, I think, early in the second year of life. That is relatively early. And so that's perhaps the most complicated task, is to tie shoelaces. And there I can see that even in the control group, not everyone at that time was able to do that. But most problems, of course, in the late treated group. So then seizures and behavior. You know that in GAMT deficiency, the seizure disorder is a very dominating problem and clinical symptom. So you can see that all in the late treated group had seizures, and only one in the younger group. But even in the control group, there was one kid that had seizures in the past, and currently seizures. Unfortunately, despite of effective treatment, 3 out of 4 of the later treated children still have some kind of seizures. Behavior, almost no. So there we, for example, asked about obsessive behavior. And you can see in the younger, early treated group, none of them, and 3 out of 4 in the later treated group. And then this is a similar task. You can also see the huge difference. And then last thing was, we asked the parents to tell us about the differences between their two children, because all the other domains where we were just asking what did your child, or what was with your child and what was with the other child. Now we asked what are the differences. And, and there you can see that there is really a significant difference. While basically in the healthy children, there is sometimes that families observe, for example, with fine motor, that the one is better than the other, or with language it can also happen, but you could see in the siblings with GAMT deficiency, there was a huge difference between the early and the later treated in each of those 4 sibling pairs. And I mean, you can read, and I think it is impressive to read those statements from the families about what they think, what are the differences. So I just want to read perhaps the last one. The boy looks like a normal child. You cannot tell that he has GAMT deficiency. She, so the older girl, she looks like a child with learning disability and that she is disabled. The difference between the 2 of them is huge, and it breaks my heart when I see how much more capable he is compared to his sister, because she could have been like that too. Mm-hmm. So, you know, that is, I think, the strongest way you can convince people, saying, you know, there is a huge difference. And so, in academic words, the study supports the notion that early initiation of treatment in children with GAMT deficiency results in improved outcomes. So that is how you write this in a publication, but you wouldn't use that to convince the legislator. You would use stronger words. So it is obvious that early treatment has significant benefits. And in order to accomplish that, you need early identification. The only way to do that is newborn screening. So what have we had on evidence before that? There is a study where we did surveying 48 individuals with GAMT deficiency. So we asked the physicians. And so what we found is that the median age of diagnosis at the time was 4 years. And the median age of treatment, when we look at those patients with mild intellectual disability or moderate intellectual disability or severe intellectual disability among those 48, then you could see the ones with mild deficits, they were treated earlier, a median age of 2 years. The moderate at 4 years and severe only at 11 years. Even that already shows you there is a correlation between start of treatment and severity of the outcome. But I always think that pictures are worth, one picture is worth 1,000 words, and a video is worth 1,000 pictures. So that was the story of John Clore. So he was in the newspapers as the baby that woke up late. He was, I think, diagnosed at the age of 12 months, so early. And he was treated at 18 months. And so Mom sent me this video because he was quite grateful for my help.
I'm ready.
So, and that is the Robinson family. And I had the wonderful opportunity eventually to meet them. I knew them very well because I was involved in the early management of the older son, Benny. So he is on the right. This is May, and this is Celia. So when we met, so Benny is nonverbal, had a very good mood when we met. And Celia was jumping around, and parents said, "Oh, tell Dr. Schultze about Benny." And so Celia started telling me what Benny can, what he can't do, and so. And then she said, "Oh, Benny, show Dr. Schultze what we are going to do on Tuesday." So he had a tablet, and then he started choosing I don't know what he started with, whether it was calendar and he selected Tuesday. Then he went in another field, family, and he chose a grandmother. And then the third one was events, and he chose birthday. So I was extremely impressed about that because I did not think that patients with GAMT can have language, because that is language. He cannot speak, but he can think in language terms. Otherwise, it wouldn't be possible. So that was impressive. But there was another thing that was perhaps even more impressive. Celia, who was jumping around telling me everything, she also has GAMT. That's the younger one, but she was treated early, you know, and when you see the difference between them, then you know how much worth it is to find those babies and put them on an effective treatment right away. So in Canada, I'm the chair of the advisory council there that advises the ministry and on newborn screening, and we have a similar process like the US, not that humongous as it is in the US, but at the end of the day, I would say we come at least to the evenly good decisions, or perhaps even better sometimes than they do. And here you can just see what the conclusion was. So we have this process also. First, it has to be nominated, then it goes through a review process, then it gets assessed, and eventually we make a recommendation to the ministry. And what are we looking at? So first, the condition. Do we have concerns? No. Then the test. So Marcia nicely explained that we have a good newborn screening test, no concerns. The treatment, no concerns. So that means it works. Societal considerations, slightly, and that is because it's an ultra-rare condition. That is why we said, okay, that one has to keep in mind. So, but there is a way to do this. Many of you may have heard about screening criteria. There were very good screening criteria put in the public in 1968 from Wilson and Youngner. And basically, those 10 criteria, you can still apply them. But there were also attempts more recently to update them a little bit. And I'm using those. It is now 12 criteria, but it is basically the same. So, and we'll just test a little bit how GAMT works. So, in terms of the epidemiology, that is kind of frequency or so, it is not only about how often you have this disease, but also how severe it is. So causes substantial, should be important health problems. So in the past, we would define this, it has to be frequent, but that's not necessarily the definition anymore, because if it causes substantial morbidity or mortality, then this is evenly important. So yes, that is the case for GAMT. Then post-screening test options. There should be an agreed on course of action. Okay, I have to. That will that will modify the natural history and clinical pathway for disease or condition, and that the results will cause improved outcomes. So that is very important because there are other conditions that would be worth to identify in newborn screening, but if we don't have an effective treatment, then we would not accept that as a screening condition. So that is correct for GAMT. And then the expected range and magnitude of benefits, for example, increased functional quality of life, indicates that the overall benefit of the screening program outweighs its potential harms. And that is true for GAMT as well. And if you check all of those points, you will find out all of them apply for GAMT deficiency. So at the end, first of all, I hope I convinced you. And second, I really want to thank our 4 families for participating in that. It was certainly not an easy task. But I have to say the families were very grateful for the opportunity to participate in this study. because they hope that their input can aid further GAMT deficiency patients and their families. So I thank personally the Association for Creatine Deficiency, and mainly Heidi, because you were very instrumental in getting this going. Yeah, I really hope that we will see more countries starting GAMT newborn screening. Thank you.